Right. Hi, everyone. I'm Krishan, one of the pediatricians and MRCPCH tutor. Today, we will have a short discussion on one of the commonest pediatric conditions which could be appearing in the pediatrics wards and day assessment units when you start to work as pediatricians in the UK. Also, this is one of the commonest scenarios which you can get in pediatrics MRCPCH theory and clinical exams. Right. Now, we will have this discussion as a case scenario to make it more realistic and more practical like. Okay, right. So we will go to the case scenario. So it's like this. You get 10-year-old child with this rash referred by a GP to day assessment unit, Royal Manchester Children's Hospital. GP is concerned that this 10-year-old child is having this rash going on for a couple of days, and he expected this to settle, but it has not settled. Now he thought at this point, I need to get opinion from the pediatrician. So the child was sent to you. Right. Now, when you look at this patient, it's pretty obvious he has got a remarkable rash, and this rash is distributed mainly around the buttock area and lower limbs. Right? If you have some amount of background knowledge in pediatrics, this is not very difficult to diagnose. What is this Henoch-Schönlein purpura or HSP? Now the question is, this topic, how will this appear in our MRCPCH exam? Now, if you have not done theory, MRCPCH theory part, you might get this as a theory scenario, right? So if you look at this one, SBA questions, you might get a question. A 10-year-old child presented with a history of cough and cold 1 week ago and now presenting with a rash. The rash is erythematous and it's more on the lower limbs and buttocks. And you might also be given a picture just looking like this. And then the examiner might ask what the likely diagnosis is. So then it's pretty obvious. The diagnosis is Henoch-Schönlein purpura. You might get several other answers for you to select. They might say, okay, could that be measles? Could that be meningococcal rash? Could this be urticaria? Could this be Kawasaki? Like that, 5 differential diagnoses will be given with this picture. Then it's obvious that it is HSP. So this is one way how this could appear in the paper. The other possibility is they might ask bit of pathophysiology of HSP, which of following are correct regarding HSP. You might be given 5 options to select the possible best option. So that again, one way how this topic could be tested from MRCPCH theory students. We will go to pathophysiology in 1 minute, like in another 1 minute time. Then we understand. If you get such a question, answering is pretty easy, right? And then you also might get the case scenario and the examiner might say that it is HSP. Then they might ask, what next investigation would you do? Or you might get a question with scenario of HSP and they might ask, what is the management, right? So these are the common ways how this topic could be tested in MRCPCH theory components. It could be FOP, it could be theory and science, it could be AKP, whatever the type of theory component, this question, this scenario could be tested differently. Then in clinical exam, MRCPCH clinical exam, the final component, this could be tested as a communication scenario. They might ask, the child was diagnosed to be having HSP. Oh, this rash, photo will be given. And then you will be asked to educate the parents as to what is going to happen to your child in next few days. Or we are going to discharge your child, and when we discharge, this is going to be the plan. So you will be asked to educate the parents. But sometimes they will say, a medical student is keen to learn about HSP, teach him. So that could be another way how this could be tested as a communication scenario. When it's a teaching scenario, a medical student, we are supposed to teach him or her a bit of pathophysiology, the complications, investigations, management. So the idea of giving that kind of scenario in MRCPCH is to see if this candidate has got a holistic idea about the topic. So in this case, HSP. And then you also might get this scenario as a video station. You will see a child with this rash, and they might ask what the diagnosis is. And then the examiner might ask from you, after you watch the video, what investigations will you do? What management options do you have to offer? Then also you might get a stable HSP child as a real patient in miscellaneous examination stations or short case stations, or you might get this as a rheumatological case if the child is having some arthritis for you to examine. Right. So this is how HSP could come in MRCPCH, different components. Now, how are we going to answer? Now, to answer these, we need to know a bit of background knowledge about HSP. If they ask, is this common? Yes, this is one of the commonest vasculitis in children. And what vessels are commonly involved? Are they large vessels, medium vessels, or small vessels? They are predominantly small vessels. So that is something that we need to know. And then pathogenesis. This could come in theory exam. Bit of pathophysiology may be tested in theory and science. So we don't know what the exact pathophysiology or pathogenesis is. However, there's a suggestion this could be triggered by some infections such as beta hemolytic streptococci, staphylococci, mycoplasma, or sometimes viruses like adenovirus. And there is deposition of IgA, immunoglobulin A, in different parts of vessels that could trigger the pathogenesis. And HSP really could be clustered in the families. So if you get an MCQ, HSP could be familial. Yes, that might suggest there could be some element of genetics involved in HSP pathophysiology or pathogenesis. We know clinical manifestations very well. The whole mark of the disease is that they will have this pink color rash, commonly seen on the buttocks and lower limbs, what we call gravity-dependent rash. And then when you get this rash, it's important to know that the rash will last for about 3 to 10 days. It's very important to educate the mother or father and say that this rash is not going to disappear overnight, right? So don't worry. So that's the natural history. If that's the patient education session, you are supposed to know all this. Actor will ask, because she or he will have a script, he will ask from the candidate, doctor, for how long will it take for this rash to disappear? So then we have to say it can go up to 10 days. And then they also can have a bit of subcutaneous edema. There could be periorbital edema, scrotal edema, scalp edema. They are all possible. Then it's very important to understand that some of the other systems could be involved in this disease in addition to skin. What are those? Musculoskeletal. So that is when the children might present with features of arthritis, arthralgia. So worth knowing that. Gastrointestinal symptoms are also common, like up to 80% of children can have gastrointestinal manifestations. They might present with vomiting, diarrhea, paralytic ileus, sometimes bit of melena, and also intersusception is one of the possibilities. Then they can have renal involvement. They can have nephritis, sometimes nephrotic-like picture, proteinuria, hematuria are possible. Then central nervous system involvement is possible, though it's rare. So central nervous system vasculitis, intracerebral hemorrhages are possible. If they ask what systems could be affected by HSP in video station or any other theory, then we need to know these are the systemic involvement. Now, there we go to investigations. Now, what investigations do we do? Now, generally, there is no specific investigation like HSP test or anything like that, obviously. So, it's more of a clinical diagnosis. However, if you do some investigations, you might see some suggestive features. One of the examples is if you do a full blood count, it might show leukocytosis and mild anemia. And then elevated ESR and CRP is possible because this is an inflammation. So inflammatory markers will be high. Then HSP, the platelet count is normal. So if you had a doubt when they come with a petechial rash, could that be ITP, immune thrombocytopenia purpura? No. Here, the platelet count is normal. And if we do a stools test, which we don't commonly do, it might show some occult blood in stools because there is a possible GI bleeding. Serum albumin could be low because they are losing protein from the gut and from urinary tract. Now, the management of HSP is largely supportive as long as they are clinically well, except for this rash and mild arthralgia. We can manage them symptomatically with analgesics. We need to make sure that they get proper hydration and then proper nutrition. Rarely, if they get complications such as renal involvement, GI involvement, you might have to start corticosteroids. If this is the case, you might first discuss with the consultant or relevant other subspecialists, say gastroenterologist or gastroenterologist, or you might discuss with nephrologist, depending on what system is involved. With their opinion, you might start prednisolone orally. In severe case, there is a place for methylprednisolone as well. Right. And then it's very important to educate the parents. Most of the trusts will have their own guidelines. So this is one of the guidelines used in Great Ormond Street Hospital, London. So these leaflets will be readily available for patients to read. And then if there's any concern, they can always come back to doctors and ask about what their doubts are. Right. So we again, if we are to go through again how this section could come in the exam, again, we understood that it could be a patient education scenario, communication station. Teaching to a medical student is the other possibility, how this could appear. And then it could be a video station where you get the rash and you might be asked to diagnose and tell me the investigation, what is the pathophysiology, tell me the management. We have already discussed. And then this could be an examination station or short case station. You may be asked to examine the rash, do general observation, and proceed with that. Right. So in that case, it's a good idea to check the blood pressure because especially renal involvement can cause hypertension. It's also a good idea to check the joints, whether the joints are involved, whether they are inflamed, any features of arthritis. And we need to quickly examine the abdomen to make sure that the abdomen is non-tender, no evidence of intersusception. So that's when this comes in clinical exam. And the theory exam, they might ask any kind of theory question like we discussed before, as long as you know a bit of pathophysiology, clinical features, investigations, and management. HSP is an area where you can get 100 marks. Summary, HSP, it's characterized by small vessel vasculitis and exact pathophysiology is not known. However, there is a possibility that this could be triggered by certain infections like Mycoplasma streptococci. And the disease is characterized by this rash, purple color rash, which is more commonly affecting or commonly located on the buttocks and lower limbs and thighs. They can present with other symptoms depending on the system involved, like abdominal pain, gastrointestinal bleeding, hematuria, proteinuria are possible. Rarely, it might go into nephritis, leading to kidney damage. Now, diagnosis is largely based on clinicals. However, we can do selective blood tests and urine tests, and sometimes, very rarely, we might go ahead and do biopsy. Treatment is largely supportive. We might have to give analgesics, proper hydration and nutrition. And then rarely, with the specialist's opinion, we might go ahead and give steroids. Right. So that's basically what we need to know about HSP. Right. So thank you very much for joining. If you need any other videos, or if you want to have some latest UK guidelines, MRCPCH clinical materials, or theory material, you can simply join our Telegram group. You search MRCPCH study forum, then you will find this very easily, and then you can join and start studying. Right. So thank you very much for joining. All the best.